today we are going to discuss about the management of, or the basis of management of cancer. So we especially concentrate on the role of chemotherapy or different modalities of cancer management, especially chemotherapy, radiotherapy, and the role of surgery. And how do we integrate these things to ensure optimum management of cancers? We may give some examples, but this is not a particular cancer management, but overall principles of management of cancers. So here with us today, Dr. Sachini Malaviarachchi. She's a consultant oncologist at Kotalawala Defense University. So she agreed today to share her knowledge with our students. So you may raise any questions. You are free to ask questions from Sachini. And we also may contribute. Sachini, so can you just outline the basic principles of management of a cancer?
Sure, sir. I will share the screen now. Right. Students, like going to base pathophysiology of cancer, and so we understand the normal cell controls by the nucleus, the mitosis, meiosis. So then that's how the normal cell works and aging process in a human being. When it comes to abnormalities that we learn during our pathology, like dysplasia, where the DNA start replicating uncontrollably, but still there are no mutations, certain characteristics, only cancer cells. So the dysplasia, then it comes to the moderate dysplasia and severe dysplasia before we see a cancer cell. If you recall your basics pathology, there are certain other factors that you may need to encounter to diagnose a cancer cell. That's how we ultimately get a diagnosis. So we try to recall all our knowledge which we learned during physiology, where the difference between normal cell and a cancer cell. That's how when we diagnose a patient with a cancer, that's where we confirm, apart from all the other signs, symptoms, and clinical findings, you may have suspicion, and when only we receive the histology, it could be either FNAC, very basic, it will only give us the cytology. Then ideally nowadays we never encourage FNAC because true cut biopsy or excision biopsy will let us know a lot of morphology, or not only about the cancer cell but also the tissue around. So from that we can learn whether this particular abnormal cells which contains all the features of malignancy, whether it's carcinoma in situ or invasive carcinoma. Do you all hear me? Do you all hear me, sir?
Yes, we can hear you. Someone has got the mic on. Can everyone please mute their mics?
Right, thank you. So then why it's important to obtain histology or to get more information about the not only the cell but also tissue as overall, where you can see whether these cells show any invasion. So that's how the cancer start metastasizing, whether it's locally or distally. So as you can see in this picture, where the carcinoma in situ, where the epithelial lining, the one of the normal cells become cancer cell. When the abnormal DNA proliferation, they might have different, like usually a normal cell cycle, we have checkpoints. When there are errors in multiple checkpoints, the normal signaling pathway doesn't work, where the cancer cells, normal cell turn into a cancer, and then you can see, as in this picture, invasion of local tissues, and certain tissues will invade the surrounding endothelial lining, and the cancer cell can get into a circulation. That's how we can see the cancer. We call it metastasizing. Just very basic. I understand here. So it's the final year medical student. So is it third year onwards?
Most of them are final year, but fourth year, third year students are also participating.
Right, sir. Thank you. So students, like what you can see in this picture, the basic characteristics of a cancer cell, where it has deviated from a normal cell. Like if I ask what are the characteristics of a cancer cell, you might start telling it has the limitless replication potential. Like that's the basic idea that you will have, but then we understand they also have acquire the ability of tissue invasion, like localized invasion, and the ability of metastasizing. Apart from that, they also have the ability of evading apoptosis. That means they evade the normal signal. They don't anymore listening to a normal signal to apoptosis. So they keep on growing. Further, they have that self-sufficiency in growth signals. So they create their own secondary messengers, where from DNA, from the nucleus, to the protein synthesis, and they start synthesizing their own protein to grow. And they have this insensitivity to anti-growth signals. So those are the other minor characteristics this malignant cell acquire. Apart from that, they have the ability of sustained angiogenesis, where you call neovascularization. So in the down half of this circle, where we understand all the risks or a cancer cell, potential risk of a cancer. And you can see the lower half of this circle, where the cancer cells start getting the potential risk. When they start growing limitless, they find hypoxic, so they have the abnormality in the pH, and you can see that's how we start attacking cancer cells. We try and recognize the lethal part, or the tumor cell, where the tumor has weak points. That's how we the principle of treatment for cancer, where from ancient ages they try and find the tumor cell lethality, or the risk factors when tumors start growing in the host tissue. So more of the time we understand any cancer, if it's operable, if it's resectable, we try and do surgery, or we try and get rid of the tumor when the patients, whenever we think of treatment modalities of a cancer, there are certain factors that we need to encounter, mainly the patient factors, where the patient's performance status. Maybe you will understand the ECOG or WHO performance scales. Are you all aware of these performance scales, students? So they might know that, isn't it? So if I summarize the performance scales.
We have some idea about this performance.
Good. Okay. So the very easy way is the think of like if it's WHO performance scale, ECOG is the reverse of WHO. So WHO is 0 to 5, whereas ECOG is again you can see the performance status 0 to 1 means patients having good near normal quality of life by the time we diagnose a cancer. So then one factor is a patient factor. Apart from that, the comorbidities decides what kind of a treatment modality that we need to do for these patients. So then first we do staging, once we diagnosed and confirm histologically, you may have like suspicion whenever you start examining a patient to assess clinical signs, symptoms, then you try and investigate, you find the features of cancer cells in histopathology, so you confirm the diagnosis and then you start staging. Once staging process is confirmed, then ideally we need to discuss in a multidisciplinary team meeting where all the specialties available to see these main factors like patient factors, tumor factors, and available treatment modalities in our setup. So depending on those three factors, we decide what is the ideal treatment for that particular patient. Nowadays, cancer treatment is personalized. So always we need to individualize treatment. So there are no hard and fast rules for managing one particular malignancy. So if you can see in this diagram, always soon after diagnosis, staging confirmed, during a multidisciplinary team meeting, what we try and elaborate is to see whether these patients are can be treated, whether we can treat them as curative intent. So if the histopathology is in situ carcinoma, very early stage, obviously we understand that these tumors can be taken easily out using a surgery, or you can use the other modalities where if the patient has comorbidities and patient has contraindications to go ahead with general anesthesia. So then how can we get rid of those tumors? Still very early stage, still curable. Surgery option is the best treatment option for most of the malignancies, except very few like lymphoma, germ cell tumors where they are very radiosensitive, chemosensitive. So after confirmation of diagnosis, most of the early tumors can 100% cure with surgery if it's inoperable. Medically, there are contraindications for general anesthesia. Still, we can cure those tumors using stereotactic radiosurgery, or high energy radiation beams. If the tumor is small, but still if the tumor is more than 4 centimeters, still we can cure using IMRT, intensity modulated radiation therapy. So when you go along this line, like from the beginning, from the day of diagnosis, the progression or the clinical picture of these patients. So when it's very early diagnosis, we can cure. If it's the locally advanced tumors, what would you do? Can we cure these patients? Yes, still we can work out, we can get together and try and cure these patients. That's what we discuss most of the time. These patients in this gray area is subjected to discuss thoroughly in our MDT meetings. What we do is whether these patients need neoadjuvant treatment to downstage tumor. So certain tumors we need to downstage using neoadjuvant treatment. Then we can make inoperable tumors operable. So that still we go ahead with all the other treatment available treatment modalities for cancer treatment. Once it's when we diagnose a patient with very late stage, with metastasized to all the places, if it's breast cancer, they do metastasize to lungs, liver, bones. If you take prostate cancer, what is the commonest metastasizing site? It is bone, isn't it? So when it comes to colorectal cancer, we can see commonly they do metastasize to liver. So similarly, if you think of the specific malignancies, before we go into specific malignancies, let's think of okay, so the lines of systemic treatment available even when it's like locally advanced. We understand when it's well localized, the treatment options are simple, either it's surgery. If medically not operable, we can have certain other options, like for example, if it's hepatocellular carcinoma, we understand if it's, we do discuss with hepatobiliary team. Yeah, if it's operable, can go ahead with surgery. Then if not, still not only radiation therapy, we have certain other treatment options like TACE, trans-arterial chemoembolization. So there are certain other modalities where we can apply for locally advanced tumors. So now just think of when it comes to systemic treatment, where when you suspect microscopic metastasis, even during your staging investigations, you may not be able to see any evidence that these patients is having distal metastasis. Still, there are certain risk factors where you need to assess thoroughly during multidisciplinary team meetings whether these patients still can we cure them, or if there are a lot of risk factors, do they need systemic treatment before we address locally? So those are the questions that you need to individualize whenever you have a patient with malignancy. Whether what is the treatment modality that we do decide depends on all these factors. So if we take certain like examples, for example, gastrointestinal tumors, when it comes to colonic or rectal cancers, so certain factors that we need, the knowledge component comes into play, right? When it comes to colonic tumors, like right-sided tumors, sometimes different with left-sided, like for example, most of the rectal cancers, when it by the time we diagnose, they are locally advanced. Whereas right-sided tumors, usually they don't need radiation therapy, and surgeon can cure these patients, and they may need only adjuvant treatment if they have risk factors, like you can see in this the common shared area in this picture. So similarly, if you think of the breast cancer, like everyone understand if it's very early, stage 1 tumors, so before that, if it's in screening or carcinoma in situ, still it's very easy to manage that you address locally. You do wide local excision. Depending on the risk factors, still we can assess whether these patients need sentinel node biopsy. So if it's very early carcinoma in situ, still I don't know, sir, whether do you recommend to do each and every patient we do breast conservation surgery with wide local excision, whether you consider to do sentinel lymph node biopsy for very early breast cancer, each and every patient, sir?
It's good if our breast team members are here, but to my knowledge in breast cancer is little behind, and nowadays we try to do sentinel node assessment in each and every patient comes with breast cancer.
Thank you, sir. So then the very early stage we do
diagnosed of having invasive breast cancer.
Yes, sir. So if it's invasive cancer, either invasive ductal carcinoma or invasive lobular carcinoma, we do resect. And there are certain components that when you have to specifically look at in histology, such as resection margins, whether margins are free or whether there are closed resection margins. Then only further adjuvant treatment decided depending on all the other risk factors. So it's very important for you all to start, like from this stage onwards, start reading the full histopathology report. Don't try and panic and read just the conclusion. It's very important to read the microscopy and macroscopic features of a tumor, where the treatment decisions are depend on certain factors that can be hidden in the main description. So that's why histopathologists take a lot of time and do these descriptions. So it's very important to read the whole histopathology report for our treatment decisions. So when it comes to locally advanced, again, we do breast conservation or mastectomy, and then there are certain other factors that we need to decide whether radiotherapy is needed or adjuvant treatment needed. So I think I thought it's overall the treatment decision when it comes to any malignancy. First, we think of if it's very early, we need to do local in its local region. We can give extra support, and then when it's metastatic, we can think of systemic treatment from the beginning. So that's the principle of the basics of cancer treatment. And I think rather than me talking, sir, you wanted to have a discussion, isn't it?
Yeah. Thank you, Sachini, for the introduction. Now you are talking about basically what you suggest, what you elaborated was sort of cancer. What cancer is? It is abnormal, uncontrolled proliferation of cells in a tissue, and these cells don't behave in a normal way and normal cell regulation mechanism. So they tend to skip those regulatory mechanisms, and they tend to go away from that particular tissue, that is in the form of local infiltration or metastasis. This can occur via lymphatics, blood, and rarely in other forms as well, transcelomic, along nerves as well. And then you said it is important to make a histological diagnosis in most of the cancers before we treat. There are few exceptions, but in most of the cancers, before you start treatment, we have to make a histological diagnosis, and preferably histological, not cytological, you said. And you said sort of the advantage of additional information with what we can gather by doing histology. Then you said it is important to stage the disease once it is diagnosed. So staging is the extent of the disease, whether it is still confined to the local organ or the tissue, or whether it has gone beyond that and
Hold on, Sumusa is connecting again. Sumusa, you can speak. I think I see you. Hello. Can anybody hear me?
Yeah, we do hear you.
Sumusa is there, I think.
So please unmute.
Saya katakan hang nam ko. Sumusa, can you hear us?
So once disconnect and reconnect, I think it's auto mute. Sir needs to unmute.
Uh,
Everyone, do you all hear me?
Sachini?
Yeah.
Yeah.
I will stop sharing.
No, that's okay.
Right.
I think till Samudusa gets back.
That's what I thought.
I
We
usually like to look at it when I'm approaching a case with cancer. I look at it as local, regional, and systemic management.
Mhm.
Do you think it's rational because the modalities available for each of these areas is quite sometimes different? For example,
I agree. Yeah, I agree, Pramod. Yeah.
if you take a breast cancer, the local management can be surgery or surgery together with radiotherapy. And the regional will be addressing the lymph nodes. And it used to be surgery, but nowadays we do sentinel node biopsy or just manage with radiotherapy or without anything. And the systemic therapy again is chemotherapy plus the hormonal therapy and the immune therapy. Am I right?
Yeah, that I think you all can see the summary of what you're talking in the screen. Is that correct, Pramod?
Yeah.
Okay.
So based on the stage of the disease, we can sort of decide on the different modalities, and there is no hard and fast rule which should be addressed. For example, if you take a metastatic colorectal cancer, we first go for the systemic therapy rather than trying to address the local disease or the regional disease. And in some diseases now, for example, colorectal cancer or breast cancer, the regional address, the lymph nodes. When we take out the lymph nodes, the benefit is not basically directly survival benefit. It is that the benefit is basically for staging, and indirectly it can benefit the survival, right? But if you take something like, I think, maybe a melanoma, you do a block dissection, that is not just for staging, that is part of the regional disease control, right?
Similarly, sarcomas or the Sir wanted to highlight this fact, which I forgot to mention. The tumors, when we categorize the tumors, there are epithelial tumors which arise from epithelial lining.
Yeah.
And there are certain other tumors which arise from the connective tissue component or the stroma, where we see all these sarcomas. So if you recall the sarcomas that you all have seen, maybe seen leiomyosarcoma, hemangiosarcoma, endotheliosarcoma. So those, if when you try and think of the pathophysiology or from what tissue that they arise, that is from a connective tissue. So then there are three categories. One is epithelial lining, that where whenever you assess clinically, you can see a breach in the epithelial lining. So that's how we know. If you take an example, if it's head and neck cancers, oral cavity malignancies, you can see a breach in epithelial lining. If you think of a lymphoma in a head and neck area or in oral cavity or back of the throat, you may see a lump, but you may not see a breach in epithelial lining. Isn't it, Pramod, that this fact Sumudhu sir wanted to highlight, which I forgot?
Yes, yeah. So cancer, carcinoma is basically a malignancy arising from the epithelium, isn't it? When we call a carcinoma. So as you said, sarcomas, and there are type of tumors which arise from the stromal tissue, right?
And the third type is the neuroendocrine tumors, which arising from neural crest cells, where you can see a wide range of tumors starting from benign and sarcoid end, and you can see a malignant neuroendocrine tumors. So this wide range of tumors, if you recall what commonly you see in your, like when you study, like in your medicine, you study about neuroendocrine tumors when you have thyroid malignancies, renal cell carcinoma, so then, and you can see certain skin diseases with multiple endocrine neoplasia, where type 1 and type 2, certain malignancies like parathyroid tumors, where you look for the other common malignancies that can associate with this MEN syndrome, isn't it?
Yeah. So the importance of knowing the difference of the molecular pathologies, that the treatment also differs in these cancers, right? How you treat a epithelial cancer versus a stromal cancer versus a neuroendocrine cancer, neuroendocrine malignancy. Those differ. So if we move on to modalities, different modalities, actually now surgery, we discuss with the students most of the time how to,
Right.
the principles of surgery in breast cancer or colorectal cancer and things.
Right.
But if we move on to the therapies, the medical therapies available, or the adjuvant therapies, as I would say. Sometimes when you say adjuvant, now these are not always adjuvant. Sometimes they can be the primary therapy, isn't it? Now for disease malignancies like lymphoma, chemotherapy might be the primary modality of treatment. So if we talk a little bit about the principles of chemotherapy, now how does chemotherapy work? Why do we give these agents? What is the action on the cancer?
Right. So by introducing chemotherapeutic agents, what we try and address the features of cancer cells, where if you recall the very first picture, so this picture, we understand the nucleus is very big in cancer cells when compared to a normal cell. So that's because each and every cancer cells, the mitosis or the cells in their cell cycle, the number of cells in their mitosis is high. So almost all the cells in these tissues, where if we take out cancer cells, we can see more than 80 to 90% of cells are in their mitosis, whereas in normal tissue, we understand they might be like well differentiated and now they are in their G phase, or when it's close to the meiosis and they start synthesizing proteins, and when it comes to near death, like they die and then they start new cells formation. That's our normal cell cycle. So mainly the principles of chemotherapy, where we address this feature of a cancer cell. So we try and hit all these phases. For example, like during the alkylating agents are the very first chemotherapeutic agents. If you see a history of chemotherapy, the first chemotherapeutic agent was alkylating agent, which was found during the Second World War, where they have found that certain nitrogen mustard, like this gas used for war, that they found among these patients who were exposed to these gases, they have found out that the cancer, those who had cancers has cured, or has reduced the size. So that's how the very first invention of a cancer, and then they have found out a lot of other features where we can address these phases. For example, so if I say alkylating agents, that they hit the DNA double strand, where there are certain, you understand, there's phosphate bond, then the pentose sugar and the phosphate pentose sugar and the nitrogen bond. So alkylating agents try and hit these nitrogen bonds. When you recall, try and recall the knowledge you have, the names of chemotherapeutic agents, cyclophosphamide, ifosfamide, the platinum agents like cisplatin, oxaliplatin, those agents come under the same group where they hit these DNA bonds. When it comes to taxanes, so the taxanes try and attack at the level of spindle formation. So all these, the chemotherapeutic agents, so it's the anti-spindle formations we use, paclitaxel, docetaxel. So whenever you see each and every chemotherapeutic agent, for example, we understand the first line chemotherapeutic agent for adjuvant treatment for breast cancer is doxorubicin. So doxorubicin again attack the DNA double strand. So we almost all the chemotherapeutic agents try and attack this mitosis phase where you so that there's a big difference between normal tissue and the cancer cells. Cancer cells had a lot of the percentage of cancer cells in mitosis is high. So then most of the cancer cells will die whenever you give systemic chemotherapy, whereas surrounding normal cells can survive. So that is the principle, basic principle of chemotherapeutic agents. When it comes to the targeted therapy, so that's where a lot of other novel cancer treatment arises. They try and find out, attack all the other potential lethal risk factors of a cancer. For example, we understand one feature of a cancer is neovascularization, where we try and attack at that point. We introduce vascular endothelial growth factor inhibitors, which is very useful treatment for metastatic colorectal cancer. We couple all chemotherapeutic agents with certain other targeted therapies. Bevacizumab is a common treatment where we can combine with chemotherapeutic agents. So similarly, there are other certain targeted therapeutic agents. We address the receptors lining on a cancer cell. So when you think of a simple receptor, like each and every breast cancer, we need to assess the cell surface receptors, like whether they contain estrogen receptor or progesterone receptor. The percentage of the receptors will decide whether these patients can be treated with hormone treatment only or whether they need adjuvant chemotherapeutic support. Plus, certain breast cancer cell surface, they have epidermal growth factor receptors, where we call HER2 new, right? So then we used to treat them with anti-HER2 receptor inhibitors like trastuzumab, or the famous brand name is Herceptin because it's the HER2 new inhibitor. So that's where the targeted therapy addressed. When it comes to immune therapy, we understand the basic principle of immune therapies. We introduce a chemical agent which boosts the normal human cell immunity. So then T cells and B cells, we know the, if you try and recall your immunology, we have acquired immunity and innate immunity. So we try and attack this acquired immunity, where with the presence of cancer cells, the body's immune system will start recognizing cancer cells with T cells, T4 and T8 cells, where this immune therapy will try and attack, try and boost this immune system. So it promotes patients' own immune system to fight against cancer. So those are the basic principles of systemic treatment for cancers. Pramod, is that enough for their level? Or students can ask questions anyway. Yeah, that's what sir wanted exactly. This should be a discussion than a lecture.
Yeah. Students, do you have any questions? So we discussed about the chemotherapeutic agents. We discussed about hormonal therapy. targeted therapy and immune therapy. Am I right?
Yeah.
So these are 4 modalities, right? If you're asked to write about systemic therapy for cancer as treatment, there are 4 modalities we can use, right? Not all can be used in all types of cancers. For example, hormonal therapy is used in malignancies related to those sites where they are responsive to hormones like the breast or the
Prostate.
gynecological prostate cancers. Yeah, those areas. So we are basically trying to control the dividing cell, isn't it? The uncontrolled division of the cells.
Yeah.
So what about the 5FU, the most commonly used agent?
Good.
when it comes to our
Yeah, that I need. So 5FU is attacking in the cell cycle. So students, if you recall a cell cycle, so I told most of the chemotherapeutic agents. Thank you, Pramod. I like skip that part. So it's very important. I should not skip that part. So I think I told you almost all the chemotherapeutic agents will attack this mitosis phase. Why we combine chemotherapeutic agents? For example, for breast cancer, we used to give FEC or AC. So for colorectal cancer, we give FOLFOX, FOLFIRI. So then 5FU and oxaliplatin. So what is the principle of this combining treatment? If one therapeutic agent like cisplatin or cyclophosphamide attacking these cell cohort, so if someone can find another chemotherapeutic agent which will attack these phases where we understand the anti-metabolites, all the metabolites happens during this S phase where you try and gather all the proteins which is necessary for mitosis. So where 5FU, cytarabine, those drugs address this phase, the S phase of DNA replication. Like they try and attack at this the protein synthesis phase. So thank you, Pramod. The students should know that fact. Yeah, it's the anti-metabolites, the 5-fluorouracil, cytarabine, those drugs attack that's the different phases in the cell cycle. So that's why we combine multiple chemotherapeutic agents to when it comes to cancer treatment.
Yeah, so it's a multi-hit.
Yeah.
Yeah, and another concept in cancer management, Sachini, is that we hear this thing called palliative and curative intent. So is there a difference when you decide on your chemotherapy regimes? Is there a difference between a palliative regime and a curative regime with regards to doses, or how do you decide this? As far as my idea is that when it comes to curative, you attack it hard, give less consideration about the side effects, but when it comes to palliation, you think more of quality of life rather than increasing the years, the number of survival years. How do you decide that?
Very important question, Pramod. Exactly, that's one factor where before we start deciding the treatment, very first we told you like patient's quality of life and the predictive survival value. Yeah, when even if it's metastatic patient, very young patient with very good quality of life, no comorbidity, still we try and hit with the adjuvant doses. So there are no hard and fast rules, but still if you go through the protocols or guidelines, when it comes to palliation, they have found out after several research where even though we try and correct them with the curative doses, usually the curative regimes are very high doses, whereas the palliative doses are relatively low doses, and patient will not get many side effects. The patient's with remaining quality of life, we try and control the tumor when it comes to palliation, especially when it's metastasized. But there are certain incidents where your practice is easy. Like where even if it's metastasized, still we can treat them with curative intent. For example, if it's oligometastatic or resectable metastatic disease, still we go for resection and then try and treat them with curative intent. So we do treat them with high dose regimes. So for example, for folks, we have 2-dose regimes. For adjuvant patients, we do give different doses. For palliative patients, usually it's relatively low doses and patients tolerate very well. But when it comes to this outcome or the response, it's surprise sometimes. We sometimes achieve the better tumor control with palliative doses, but what is the difference? We understand these patients do recur within a year. So that is the difference between high doses, the curative doses, and palliative doses. So why we do give adjuvant treatment following resection? So if we resected, why still patient need adjuvant treatment? That is to address microscopic metastasis where before we resect the tumor, as you all saw very first picture, that they creep through the blood vessels and they can metastasize. Still, we may not be able to see those deposits in our staging investigation. To visualize in a radiology, there should be at least 1 in 10 to the power 9 cells. So before that, there may be hidden microscopic metastasis. So to address those metastases, we used to give adjuvant chemotherapeutic agents. So that's why we have certain number of cycles, either 6 cycles, 3 weekly, weekly 12 cycles. So there are schedules where after a lot of studies, they have found out if you have given this number of chemotherapeutic cycles, so one chemotherapeutic hit will kill 1 per log amount of cell load. So then if you have done 6 cycles, they have found out, okay, then the chances of remaining even a single cancer cell is 0. So that's why we have quite certain number of therapeutic cycles in adjuvant treatment, whereas you don't have particular number of cycles in palliative treatment, where you can continue treatment till disease progress or when the tumor cells override our treatment, or then if the moment patient develop toxicity. So the principle of continuing systemic treatment in metastatic disease or palliative setting is till patients without compromising their quality of life. If we can control the cancer without toxicity, we can continue that therapeutic agent. The moment we found that it is no longer responding, we need to change over to the next line of treatment. So that's why we have this first line, second line, third line. So most of the subsequent lines are palliative and we try and address symptomatic cure. So symptomatic treatment. So that is why always the cancer treatment, we respect the quality of life. Apart from all these factors, we do respect patients like wish, patients and the patient party. Apart from the tumor factors, the comorbidities, available treatment modalities, we do respect what patient decides. For example, when it comes to prostate cancer, there are more than 5 or 6 treatment options for one particular stage. Like if it's a very early stage, you can do TURBT, you can resect the prostate, you can do robotic resection, can do brachytherapy, active surveillance. What is active surveillance? Students, I think Pramod, they know what is difference between active surveillance and the watchful waiting. So similarly for each and every cancer, depending on the risk factors, all the treatment modalities, the decision of doses differ.
Yeah, so I think now, as you described, all these chemotherapeutic agents are aimed at attacking the dividing cells. So Now, we have dividing cells in our normal tissues as well. How do these affect our normal dividing cells? Is this why we get all these side effects, mainly where we can see with loss of hair and sometimes gastrointestinal tract is affected? Can you elaborate on the side effect profile of these chemotherapeutic agents?
Sure, Pramod. Yeah, that's very important. So we try and hit rapidly growing cells or the cells in mitotic phase, or these cells who are in replicating phase will be killed by cancer cells. So then you have to think of what are the normal cells which have this high growth rate. So if you recall, like your nails are growing, hair is growing, and you need bone marrow to produce white cells. If I ask a question, what is the lifespan of a white cell? It is 24 hours. So then we understand white cells are regenerating like regularly in bone marrow. So then hemoglobin, platelets. So these are the areas where we do have rapidly proliferating cell colonies in our normal tissue. So hair, nails, as you said, the GI tract, because the lining epithelium always need to be refreshed. So then there are proliferating if you take a colony of these normal cells of GI tract, the cells in M phase or the mitotic phase is higher than a normal other resting cells like liver cells. So then after each and every chemotherapeutic agent, patient do get the GI symptoms like nausea, vomiting, diarrhea, and they do get the nail problems, the hair loss, and then patient develop neutropenia, anemia, thrombocytopenia. So that's why we try and hit cyclically. We let the normal tissue to recover. So for example, so breast cancer adjuvant setting, adriamycin and cyclophosphamide, we used to give 3 weekly. For folks, we used to give through 2 weekly. So that's the keeping this gap is to allow normal cells to recover. Whereas we understand most of the colony of cancer cells already hit because a lot of cells are in there emphasizing among this cancer colony. Is that
Yeah, I think it is very important the students you understand why these are given in these cycles and why patients gets these side effects, because most of the time they are more worried about the side effects like losing hair, affecting nails, and having gastrointestinal side effects, because all these are actively dividing cells, so they all get affected with chemotherapy. So do you want to discuss on the radiotherapy? Do we have some of the side?
so till
So shall we move on to radiotherapy then? What is the basis behind radiotherapy in managing cancers? Why do we give radiotherapy? What's the action? How do they affect the cancers?
So radiation therapy, like I don't have a picture like to demonstrate. So when it comes to like try and concentrate on this DNA brand, like, and if someone directing a torch light beam to this DNA strand, we understand the light beam goes through this DNA strand. So what we use in radiation therapy is high energy light beam, where when the high energy beams go through these DNA strands will die. But this is not the main way of killing cancer cells during radiation therapy. So we have 2 modalities of killing cancer cells during radiation therapy. One is this direct hit, that we call it direct. But there are certain other indirect. So majority, more than 80% of the cells will die due to this indirect effect. What is that indirect effect? Indirect effect is when the cell radiation goes to the cell plasma, when it's not goes through the DNA strands, there are, what is the commonest chemical agent in a cell? Water, isn't it? So when these radiation beams hits the water molecules, oxygen free radicals will generate. These oxygen free radicals are toxic. So then there'll be like oxygen free radicals will attack DNA strands and the cancer cells would die. So those are the two modalities where we use to kill cancer cells using radiation therapy. One is direct with the direct radiation beams. So whenever the radiation goes through the cancer cells, even as beams goes through plasma, more than 80% of these cells will die. So we obtain indirect heat. The cell death, the majority of the cells die due to indirect heat, whereas certain other 20 to 30% die with direct heat. Did you understand? I'm not very sure.
Yes, I think was very clear, isn't it? There is a direct damage into DNA, and also there is indirect damage by creating oxygen-free radicals, because you give energy to electrons and make them jump up from your physics or chemistry, from your A-level days, right? They make oxygen-free radicals, O minus or dot, and they indirectly attack these cells. And when we take radiotherapy, we use it as adjuvant treatment or a neoadjuvant treatment, as well as primary modality in some cancers, isn't it?
Yes, a lot of brain tumors, when the tumor locates in high-risk area where the surgeon would not be able to address, like deep-seated tumors or certain brainstem tumors.
Yeah, and also I think in upper esophageal cancers or laryngeal cancers, because if you try to do surgery, the morbidity is high, right? They're going to lose their voice and swallowing mechanism and so on. So for those also we offer radiotherapy as primary modality, isn't it? But when you take breast cancer or colorectal cancer, in rectal cancer, we offer it as an adjuvant treatment. In rectal cancer, as a neoadjuvant treatment. And if you are doing breast conservative surgery, we offer it as an adjuvant treatment to prevent local recurrence. So you can use the same modality in different ways based on the cancer biology. It's very important to understand the cancer biology when you decide the modalities of treatment, isn't it, Sachini?
Yes, true. So that's why we understand the pathophysiology of cancer cells.
So, Mudhu sir, you want to add something?
Can you hear me now?
Yes,
we can hear you.
Right. I'm sorry, sort of, but I was with you. Now, Sachini, you said radiotherapy can kill cancer cells in two ways, and it can kill normal cells as well, I suppose. Hello?
Yes, it can kill normal cells as well. That's why whenever we give radiation therapy, we need to define the volumes. So if I elaborate a little bit.
Elaborate on that?
Yeah, so if I elaborate a little bit more, like we used to do CT simulation where you can get images of a patient, which you try and find out the gross tumor, which is visible like in a CT. But sometimes you can see a tumor more clearly in PET CT scan than ordinary CT scan. So whenever we have all the other diagnostic images available, what we can do is we try and fuse all these images. Like if it's a lower rectal cancer, we have MRI of lower rectum before we decide treatment. Then only we can see the mesorectal threatening and whether the tumor is involved in the mesorectum, whether the perirectal tissue involved. So that won't be able to clearly visualize in ordinary CT scan. So we do a CT scan in a treatment, like connected to a treatment machine. We do a CT scan So to these images, we fuse the previously diagnosed MRI or PET CT scan. Then you will be able to visualize the tumor active cells. Then we try and volume them. There are three main volumes we need to concentrate. One is gross tumor volume. We call GTV. So we draw a gross tumor 1 millimeter by millimeter. So it's like you're doing a surgery. So you draw a gross tumor. Then we try and give margins to gross tumor. Depending on the tumor risk factors, the anatomy, for example, if you draw the gross tumor and if you give 2 centimeters margins, suppose if it's esophageal tumor and mid-esophageal tumor, if you give 2 centimeters margins, then you can see this, if it's margins from gross tumor is the CTV, that is clinical target volume, where we try and elicit the microscopic spread of the tumor. The risk of microscopic spread area is addressed with this clinical target volume. So you have to edit it before we give, before we delineate in the beams, we edit this clinical target volume depending on the surrounding anatomy. Like if it's a mid-esophageal tumor, you give margins from gross tumor, 2 centimeter margins, then you can edit. Like if it's overlapping the heart, definitely we understand if the fat plane is preserved, it has not invading and there's no risk of microscopic spread in that area. So you edit it. And then if it's gone to lungs again, if you're very sure that there's no risk of microscopic spread, you still again edit. So similarly, you volume the second set of risk areas. First you volume the gross tumor, then volume the clinical target volume where the microscopic risk is there. Then you try and give margins for setup errors and human errors. It will be either 1 millimeter or 2 millimeter, depending on the setup. We do that. Then only we organize beams. When we organize beams, we try and assess the surrounding normal structures. As Sir said, if it's close to heart, always there's a tolerance dose. So we can't exceed those doses. When it comes to rectum or pelvic tumors, the dose limiting factor would be small bowels. So in each and every area from head to toe, if you recall, whenever we deliver radiation therapy, we have to be very careful of all the surrounding normal structures where we analyze before we commence treatment, we analyze the summary or the total dose to surrounding normal structures and make sure that they won't exceed the tolerance dose. Then patient won't get much of a side effects. So they are well tolerating the radiation therapy whenever you are very careful with this voluming. Is that enough, sir? Pramod, do you all hear me?
Yeah, we can hear you.
Right.
Yeah, Sachini, now what you are trying to say is when we are treating a cancer using radiotherapy, the main limiting factor of the dose is the safe dose, which is tolerated by the normal tissues.
Yes.
So to get the maximum advantage of radiotherapy, we have to target this radiotherapy to the tumor area. For that, we do different radiological tools. There are volumetric assessment, and to find sort of the places to reach this radiotherapy waves, radiation to the target organ. We avoiding sort of bony landmarks like that. So, so when you sort of now when we are giving radiotherapy like that, sort of we fractionate it and give. Why do we fractionate it? Why can't we give it at the same day? Or what's that rationale behind
the principle of fraction? The rationale of fractionating is again the normal tissue constraints. Like people have used this, one can think of, why can't I give total dose to the tumor?
Yes.
Yes. So then we understand, if we think of the mechanism of action of radiation, still if you have given the total dose, suppose we want to give 70 gray to prostate, why can't we volume the prostate and give all 70 gray in one shot? We can't do, because we understand only few. There may be some other cells which didn't hit by these beams. So some part of the beam will go through DNA strand, some part will generate oxygen-free radicals, but 100% the tumor control won't be achieved with the total dose. So then the day by day we understand there are factors like the tumors try and evade. So tumors try and regenerate, regrowth, and reoxygenate. So that's what these tumor features we used in radiation therapy. So we fractionate this because there are certain component of cell cycle cells where today when we hit with radiation therapy, certain portion of tumor cells will be in their G phase. So that won't die with this today's radiation, but they regenerate and regrow by tomorrow. So then tomorrow's hit will catch these the unaddressed cells. So that's why we fractionate. That's one reason. Then the other reason is we understand the primary principle of killing cancer cells with radiation is oxygen-free radicals. So if this tumor cells are hypoxic, the amount or the percentage of tumor cells die with the radiation will be less. So then you need to allow reoxygenation. That's another reason why we need fractionation in order to achieve complete pathological response. Otherwise, there are certain trials that they have tried with the way everyone can think of, why can't we kill with high doses? So what we do in SRS or stereotactic radiosurgery, we used to give single 19 gray or 20 gray for certain specific indications only. But if you are targeting or heading for cure, then we need to follow these fractionation. Why? We need to address complete pathological response. So we are trying and encounter 100% cell killing using these the regimes. Is that?
Yes, that is very clear. So now we know two things, that we have to decide the radiation dose based on the tolerance of the normal tissues, and this is to be fractionated to get the maximum benefit of the radiation therapy. Sachini, now what are the different modalities of delivering radiotherapy to a target organ?
Right. So we can give radiation therapy through external beam, where we call external beam radiation therapy, or through brachytherapy. So brachytherapy, the principle of brachytherapy is it's like if the external beam radiation therapy term itself, like a torch beam, where from externally you deliver this radiation beam targeting to one specific area where the cancer locates. When it comes to brachytherapy, we use short distance radiation. For example, beta rays and alpha rays, where you try and locate the radiation source very close to the tumor. That is the principle of brachytherapy. Commonly, we use brachytherapy in cervical cancer, because cervical cancer, so each and every tumor types has the radiation sensitivity. So lymphomas are very radiosensitive. With small dose, we can cure them. But when it comes to cervical cancer, they are radio resistant. Still, stage 2 or 3 cervical cancer, we used to achieve cure. When it's inoperable, we cure them using chemoradiation therapy, concurrent chemoradiation therapy. So while some part is hit with the radiation, the chemotherapy will hit the unaddressed part. So that's why we get complete cure using concurrent chemotherapy and radiation therapy. When it comes to brachytherapy, we try and introduce the source very close to the tumor tissues. So this short distance radiation therapy will kill the tumor cells. And because of this nature, the so short distance nature, that won't give much of a toxicity to the surrounding structures like rectum. If you recall the cervix, the most posterior structure of the cervix is the rectum. Rectum can only tolerate either 45 to 50 gray, but to get cure, we need to give 70 gray to cervical cancer. How can we achieve 70 gray using external beam radiation therapy? We can't. So we try and combine external beam plus brachytherapy. So there are certain radiotherapeutic agents we used to call interstitial brachytherapy. So in cervical cancer, what we do is we introduce a tube close to the uterine cervix and we deliver the radiation source. So we delicate certain points along the tumor and we let these radiation source to expose to these allocated marks where we can see the cancer cells will die when the radiation is emitted, like when we set up the marks time. When it comes to interstitial brachytherapy, what you can see commonly in sarcomas, very rarely certain, like early good old days, we used to give it for breast cancer. Nowadays, we no longer practice that, but still interstitial brachytherapy is where you insert the tubes using these tubes towards the tumor cells. Like suppose we have a sarcoma in thigh. So because of the tumor nature and the anatomical location, the surgeon decides, I may not be able to achieve the required margins, resection margins. So during MDT meeting, we decide, so post-surgically, we introduce this interstitial brachytherapy, like introducing tubes. So using these tubes, we introduce the brachytherapy source where the radiation source is directly introduced towards the tumor bed. So this is one another indication where we use brachytherapy in surgery. And certain other brachytherapy indications are esophageal tumors. If it's inoperable esophageal tumor, and if the stenting is not possible, even after stenting, if the patient has a lot of comorbidities where you can't introduce external beam radiation therapy, so you can have the beauty of introducing brachytherapy through the endoscope or the tubes we introduce to the required place, and we can release the short distance radiation beam using brachytherapy. Certain other radiation therapeutic modalities, the iodine, radioactive iodine, where you introduce this radioactivity systemically. So it's the iodine 131 capsule is swallowed by the patient who underwent thyroidectomy. We understand following thyroidectomy, we have the option of doing I-131 scan to assess the metastatic deposits. But and we know the high-risk patients need adjuvant radiation therapy where we used to give this internal radiation therapy, giving systemic radiation capsules. The I-131 will release beta radiation, which will only travel through 1 meter distance. So that's why certain patients who are with I-131 treatment, that they need to be isolated, but still we do visit them. When we treat them, you have to have this 1 meter distance. So when you treat patients with radiation therapy, these principles, TDS, like it's the time, distance, and shielding. That's how the treating staff or the why radiation side effects you have to keep all the other normal population or the relatives or the family members away from radiation therapy when you introduce a capsule or systemic treatment to a patient. So that's why you understand certain patients we need to isolate following radioactive iodine treatment. And still how it kills cancer cells is radioactive iodine is uptaken by iodine hungry cells. So we make them hungry by stopping thyroxine for 1 month, where you can see these patients TSH level should be more than 30 when to obtain the required benefit from radioactive iodine. So the other alternative is if patient is high risk to keep hypothyroid, we can give recombinant TSH directly more than 30, then the radioactive uptake will be maximum. So that's another way of treating using radiation therapy for cancer treatment. So is that enough?
Yeah, very clear. And one last thing about the radiotherapy, or two things we want to clarify. Now, you just touch on this as well. Now, certain sometimes when we want to give radiotherapy and want to maximize the effects of radiotherapy, we combine it with chemotherapy, like in rectal cancer. How does chemotherapy increases the efficacy of radiotherapy there?
Yes, the usually why we combine chemotherapeutic agents with radiation therapy. Again, the principles like radiation therapy will kill the most of the cell colonies in their M phase, whereas usually what the combining chemotherapeutic agents are either cisplatin or 5-fluorouracil, where the 5-fluorouracil gemcitabine, these chemotherapeutic agents are antimetabolites. So in a cell cycle, the cells in mitosis, major part will kill with radiation therapy, but this cell colony in S phase will address by these chemotherapeutic agents. So cisplatinum, again, they have the different action. One action through the mitosis, like killing cells in DNA, whereas certain the cisplatin can act on the cell in metabolite, like they are in S phase. So we try and address almost all the parts in the cell cycle when we combine chemotherapeutic agents with radiation. Radiation will kill the M phase portion, whereas the chemotherapeutic agents will try and kill the S phase cells.
Yeah. Thank you, Sachini. Now, what are the now we have heard you said about cobalt machine. Then you mentioned about IMRT. Then linear accelerators. These are different ways of delivering radiotherapy. What are the differences between these?
Right. So cobalt machine, 3D CRT, IMRT, all these are the ways of delivering external beam radiation therapy. So before the invention of high energy linear accelerators, since Marie Curie started introduced that the cancer can be killed with X-ray beams. So since then, the evolution of radiation therapy found out that the cobalt-60 or iridium were main radiation therapy sources where we used to give this external beam radiation therapy to kill cancer. But they have found out certain drawbacks using these the naturally occurring the radionuclide materials. What is the drawback? That they are decaying. So once they decay, the treatment time is prolonged. So when you have the cobalt-60, but in 1 year time, if today you have the new cobalt-60 source, you can be treated, the patients can be treated with one treatment session. We can finish within 5 to 10 minutes. But when it comes to 1 year after the radiation source, the treatment session will take 20 to 30 minutes because it has decayed and you need more and more time of exposure to achieve that amount of radiation dose. So those are the problems with cobalt-60 machine. That's why the invention of high energy linear accelerators, where we use high electricity beam, and if you recall your physics, electricity beams has high energy electrons. This electron flow will hit the tungsten target, and then the target will emit the gamma radiation. So X-rays and gamma, those beams physically, they behave equally. So these gamma beams will be used in high energy linear accelerators. What is the difference between 3D CRT and IMRT? So three-dimensional radiation therapy and intensity modulated radiation therapy. So the difference between these two is, like, initially, the moment we found out that radiation can kill cancer cells, we try and treat with a square shape. So then with time, we try and modulate according to the tumor shape. What is the advantage of modulating according to the tumor shape? Because you can stay away from a lot of side effects due to exposure to surrounding normal structure. So when it comes to IMRT, so you have the radiation therapy source, or the beam exiting head, we call it head, contains multiple the doors. So when you have 100 doors of opening and closing at the same time, so multiple radiation beams shape up according to the tumor shape. When it comes to 3D CRT, you may not be able to fine tuning, but it may be better than conventional radiation therapy, where we use the natural source, the cobalt-60, where you can treat as a box. You only can do lead shielding. Suppose you are treating abdomen and you need to shield the kidneys. We had thick lead according to the kidney shapes, and we try and fix that to the treatment head to not to exit beams along that area. So that is how we like try and reduce the risk of exposure to normal structures during cobalt-60. When it comes to high energy linear accelerators, we try and get the same shape of the tumor. Is that enough?
Yeah. Thank you. One last thing. Can you tell a little bit about what adjuvant therapy is and what is neoadjuvant therapy? What's the difference between these two?
So neoadjuvant treatment we introduce before surgery or before intervention. So adjuvant treatment is once the tumor comes out, it's to address the risk of microscopic metastasis surrounding the area. Neoadjuvant, where you hit the cancer cells, so where you target the gross tumor. Neoadjuvantly, when you treat neoadjuvantly, you target the gross tumor. Why neoadjuvant treatment is popular among certain cancers? Because that they have found out, for example, colorectal cancers, when it comes to the threatened mesorectum. So then we surgical team try and get the margins away, like, so the morbidity and mortality will be high if you have the ability of controlling using the chemotherapy and radiation therapy. If we can kill all the surrounding cancer cells, so if we can kill the gross tumor, so that is an advantage. Before we perform surgery, we can kill most of the portion of cancer cells, and we can address the surrounding regional microscopic spreading area using radiation beam, where patients' morbidity and mortality is less compared to upfront surgery. So commonly, what neoadjuvant chemoradiation therapy is useful in locally advanced colorectal cancers, esophageal tumors, gastric cancers, and certain other, like, it's the novel, there are researchers that they try and introduce for pancreatic cancers. Now it's, they have found out the neoadjuvant chemoradiation therapy gives benefit, and then the surgical resection or the surgical outcome is much better compared to patients we go ahead upfront surgery without neoadjuvant. Adjuvant means once the tumor has resected, still if we find there are risk factors and patient is benefited addressing the local regional area using radiation therapy to address the microscopic mets, where we need to give adjuvant treatment. Right, sir? Hello. Hello, Pramod. Yeah.
Yeah, I think that was clear, Sachini, and I think Samudra sir has got disconnected. Anyway,
Right.
there are a couple of questions from students. One is, what are the novel therapies? I think we discussed about the novel therapies, the targeted and the immune therapy. Is there a place for vitamin B19 in cancer treatment? Is there?
It is not a cancer treatment modality that comes under other supportive. They are on trial basis, and there's no basis of vitamin B19 for cancer treatment.
Right. Clear. Facial cancers, the external beam therapy or brachytherapy would be better.
That's a good question. So the head and neck tumors, usually when you have the facility of IMRT, intensity modulated radiation therapy, the patient's discomfort and the compliance is high with external beam radiation therapy. But still, if it's recurrent, recurrent cancers, yes, we have the ability, like if patient needs re-radiation, we need to use short distance radiation because we can't risk all the surrounding normal tissues anymore. When it comes to recurrent tumors in head and neck area, brachytherapy or interstitial radiation therapy is useful. However, as first-line radiation therapy for adjuvant or primary radiation therapy, external beam is the best treatment modality.
Right. And one last question. How long do you recommend a patient to stay away from others after giving a radioactive iodine, after completing treatment?
Okay, so it depends on the dose, the radioactive iodine treatment. We have 4 different dose regimes depending on the risk of patient. Like if it's very low risk of recurrence, we give 30 millicurie, which is a small dose. When if it's moderate or intermediate risk, we used to give radioactive iodine either 100 millicurie or 150 millicurie. And for high risk patients, we used to give 200 millicurie. So before we discharge patients, we using the our like assessment meters, we used to measure the radiation which emit from patient. So depending on the radiation by the time of discharge, we advise usually when it comes to 30 millicurie, only 2 weeks is adequate. When it comes to 150, it will be 3 weeks. When it comes to high dose, usually 4 weeks of isolation is required before exposed to the society.
Right. Yeah, I think that's very clear. I think we discussed about wide area of cancer management principles. The objective of these students was not to give you point by point facts about managing each individual cancer, but for you to understand. I mean, I don't think that's possible in any single lecture. So this was basically to give you an idea of the principles behind cancer treatment, the different modalities available for different treatments, for different cancers, and then the sequence of these modalities change based on what our objective is. And there is no hard and fast rule which should come first. And these are all, sometimes these may be primary modalities, sometimes these may be combined with surgery. And also we discussed about the physics behind these treatments, so you will understand why a certain chemotherapeutic agent is given in cycles, why radiotherapy is fractionated, why radiotherapy is given at different time intervals, and so on. So I guess you got a general idea now when you study different cancers, breast versus colorectal versus pancreatic or liver. Now you can basically compare and contrast the different modalities based on this knowledge, right? And if you come across any questions while you do that, so as I said, I want to stress again, this is not for you to handle MCQs or right answers. This is for you to get a get a structure, right? You first need to understand the principles behind these modalities before you go and study facts about individual modality. So if you get any questions, we are always happy to answer them. You can direct them to us and we will direct forward it to Dr. Sachini Rasnayake, and she will be happy to answer them, right? So Sachini, thank you very much for your time.
You're welcome.
Thank you very much, and wish you all a good night. Okay.
Good night.
Bye.
Thank you, Sachini.
You're welcome, sir.
Good night.
Good night. Good night, sir.
Thank you, madam.